So, over to Dr. Jyoti. Dr. Jyoti Prakash Vyas is senior retina surgeon in Girdharai Hospital, and he has a lot of experience in dealing such cases. Sir, to you.
Thank you, KSOS and Dr. Anubhav, for giving me this opportunity. Um, I'll be talking about assessing diabetic retinopathy with wide field imaging. It's basically a talk which deals about screening strategies for diabetic retinopathy. The diabetic retinopathy, or per se any screening strategy, can be broadly classified into either effective screening, opportunistic screening, or targeted screening. Anything which is called an effective screening, it should have at least a 20% risk reduction in clinical sequelae. Opportunistic would be not enough to meet the need of the load of patients who have the disease, whereas targeted is something which we aim at so as to address the population at large. So, looking at the evolution of diabetic retinopathy screening started from way back around 35 years when the ETDRS study came out, and they introduced us to what was known as the diabetic retinopathy severity scale. And this has been in use for the past 35 years or so and still continues to be used regularly on a daily basis. So from 80-85, these initial ETDRS study enrollment started after the results were published in 91. Till the present day, we are still using DRSS. Now, the change came after an initial study, a publication by Dr. Silva et al. In 2015, which highlighted the features of wide field photography and angiography in diabetic retinopathy. So the photograph which you see to your left of your screen happens to be a wide field angiography, and the delineated that clover leaf pattern which you see is actually the standard 7-field photograph, which was identified in ETDRS, which has been used over the past so many years. So you can see the amount of area which we used to see and what the present modalities allow us to see. So there is a massive increase in the area which we can see. So it's around 82% of the retinal surface extra which we see with the newer wide field imaging modalities. So addressing this question, actually the DRCRNet protocol AA was formulated, and the results which came out, they showed that as I said earlier, the peripheral lesion detection went up all by around 82% of the retinal area, as opposed to the 30 to 35% of area which was seen in the earlier SS7, that is the standard 7 photographs at the posterior pole. It also helped in assessing larger extensive areas of non-perfusion and what was labeled as PPL, or the predominantly peripheral lesions. Now, if you remember, classically, diabetic retinopathy has been defined as a disease of the posterior pole. But now, with the presence of the ultra-wide field imaging, we are able to assess the periphery as well as the importance of identifying predominantly peripheral lesions in diabetic retinopathy. And it was found that these areas correlated with systemic comorbidities and rapid progression of disease over a period of time. So they said the main highlight of the disease was that NVE outside the standard 7 fields was present in about 12 to 17% of the patients who were studied during the 4-year study duration of the protocol AA. And compared to the standard imaging, ultra-wide field fluorescein angiography detected 4 times more non-perfusion as opposed to the normal standard one, and 2 times more NVE. So we were able to identify more treatment requiring diabetic retinopathies at an earlier stage, and probably it would extrapolate to a better long-term outcome in these patients. So the findings were that if you look at the DRSS scale, severity scale between the standard 7 field and the ultra wide field, 48%, about 50% was almost half were in exact agreement between the two. Amongst the total, about 88% had at least a step of difference between the severity scaling. The important feature is an extra 12.5%, I'm sorry, 12.5% showed a more severe form of diabetic retinopathy as was assessed on the standard 7-field photograph. And out of all the patients who were enrolled, 41% of the patients had predominant peripheral lesions. So the implication of this are we tend to have an enhanced DR assessment at an early on initial screening stage. We can refine prognostic tools. Now this, after the AA protocol, this has been incorporated into the most upcoming clinical trials, and it has the potential for a paradigm shift in the treatment protocols for diabetic retinopathy in the future. What according to protocol AA was that only ultra-wide field angiography and not ultra-wide field photography was important, but we at our center had a publication which was done in 2021 which showed that the sensitivity and specificity of doing a pseudo-color ultra-wide field photography, not fluorescein angiography, also had a reasonably high sensitivity and specificity to detect retinal neovascularization elsewhere and at the disc also. Another important feature which was found out from our hospital, we had done a study in which the PPLs were associated with 20 to 23% of patients had associated coronary artery disease. So any patient, when you examine and is found to have a predominantly peripheral lesion, they are said to have, they should be advised a cardiac evaluation, since at least a quarter of them may have underlying cardiac comorbidities. Another thing which is to be added, so we have had ultra-wide field photography, ultra-wide field fluorescein imaging, so why should OCT be left behind? This is a pilot study which was done around 2-3 years ago. It was a very small study, around 30 or 32 eyes were examined, and this answered the basic question. One of the indications, if you remember from our basic postgraduate training, that fluorescein angiography is indicated to differentiate between IRMA and NVE. Now this is the question which answered here non-invasively. What they did an ultra-wide field imaging OCT on the areas where they had an IRMA which was suspicious looking. So any lesion which they found above the ILM was an NVE, and anything below the ILM was an IRMA. And they found that around 23.7% of the presumed IRMAs actually were neovascular NVEs. So an extra of 1/4 of the probably 25% patients required the classification changed from a severe NPDR to a PDR. So now, since I had read this article, I had 2 or 3 patients in which, this is one of my patients in which I had done a fluorescein angiogram, and if you see in the infranasal quadrant of the right eye, this patient has a leakage, but this leakage doesn't characteristically show you the pattern what you would see on a neovascularization. Plus, there is no surrounding capillary non-perfusion. So the initial idea, if you just look at the angiogram, would be you are looking at an IRMA. But if you do an OCT, you can see to the far right of your screen, there is an element which is rising well above the ILM. So this is a surface NVE which was caught on early, and we did the pan-retinal photocoagulation, and the patient is doing well for the past 6 months or so. These are the photographs which show you the requirement of a peripheral wide field evaluation in these patients at baseline. Just looking at the posterior pole, you would probably think it's a moderate NPDR, but if you go all the way till the 200-degree photographs, these actually show you sclerosed vessels, they will show you blot hemorrhages, and few not microaneurysm, something like a enlarged microaneurysm like pattern seen in the periphery, which may give you an idea of the disease severity. These are some examples which look very like a mild, moderate or a severe stage, but when you do an angiogram, you can see a well-defined neovascularization all around. These are the similar lesions. Due to paucity of time, I'll just skip through them. Similar details coming out. So the take-home points from the talk would be that ultra-wide field imaging, fluorescein angiography and OCT will non-invasively help us to define a potentially treatable or a vision-threatening diabetic retinopathy which may be missed on conventional imaging techniques. Thank you for the kind attention.
Thank you, Dr. Jyoti. One or two points here. Diabetic retinopathy is always a disease of the posterior pole and
Yes, sir.
below the equator. Now,
Yes.
this is brought out that diabetic retinopathy also is a peripheral disease.
Yes, sir.
An important thing is with wide field and imaging and fluorescein, if you detect lesions, it doesn't mean that patient has got, it not only means that patient has got ischemia or new vessels, it means that they can have systemic comorbidities also. So that's something very, very important. That's something that's come new. And the third thing here is regarding IRMAs. See, IRMA is always mostly a clinical diagnosis where, the IRMAs are really flat. They don't cross the major arcades. And if you do an angiogram, they don't leak.
Yes.
So I think, that point is slightly
A grey area, kind of a grey area.
And I think, you should still go with angiogram and you should rely on OCT if you really are not sure and if you want to really go about it.
Yes.
Okay, thank you, Jyoti.
Thank you, sir.
And one more thing I want to just add, sir, that in our clinical practice, a lot of us will not be having wide field imaging for angiogram. So it's very important to do a good indirect ophthalmoscopy. And if you see CRVO type of big hemorrhages in the periphery, that is a very high suspicion of having PDR. In such cases, please do angiogram, which is very important, which can give you a very good clue, and you can diagnose PDR in very early stage before having any advanced vision-threatening diabetic retinopathy. So any other questions from the audience? Not point, large blot hemorrhages. Dot hemorrhages might not be of much significance, but if they are big hemorrhages, that is definitely of significance.
Now for PDR detection, we don't use angiogram much. It's mostly a clinical diagnosis, and only if you're really suspicious when you don't see anything actual, but you still suspect. And there is a condition called featureless retina, where there is like an ROP, aggressive ROP, where there is so much of ischemia that there are no new blood vessels. So these are so always do angiogram. Not as I don't recommend it as a routine procedure, but whenever you have this gut feeling, that something is you're not picking up, then definitely you should go for an angiogram and see. And if you look at the TDR's criteria for severe NPDR and very severe NPDR, there is 15 and 45% chance of progressing to PDR in the next 1 year. So suppose a patient cannot come for follow-up, he's going to Gulf, he's not there. There is no harm in doing a PRP also, it doesn't matter.